So my talk is my algorithm, which is, I have to thank Dr. Krishnar for valuing. It looks like he values my opinion and how I treat this. So I'm going to start with this case. It's a 66-year-old female with severe right low extremity claudication. You see there is angiography, just a run, with very long, diffusely diseased vessel. You kind of appreciate a little bit of calcium there, maybe moderate at most, and but doesn't look too bad. And you see DSA corresponding images as well. So we started with just to fill that lesion with a 40150 balloon, and you see it's not expanding in at least 2 spots there. Okay, not a biggie. Let's do shockwave. So we put shockwave balloon there, which is 6 by 80 E8 balloon. Inflated it, did multiple pulses, pulled it back, and force making sure that the emitters right where that bad spot is. Still didn't do anything to that particular segment. All right, so next step, rotational atherectomy. We tried to do jet stream, which was 2.4, 3.4. The problem was that the burr would not cross the lesion. We were doing multiple pecking, trying it, to get through the lesion, and it didn't do anything. So question is, what's next, right? We found that because we did plaque modification techniques already. We just tried simple balloon. We did shockwave. We tried to cross with the jet stream. Nothing worked. We thought that maybe we modified that enough to get a coronary balloon through this non-compliant balloon and just crank it up to very high atmospheres. And it actually did work. It's at 26 atmospheres, this balloon went up. And eventually, we just did balloon angioplasty of the whole lesion and implanted this drug-eluting stents there with a pretty good result. So sometimes if the lesion doesn't even look horribly calcified, it can be quite challenging. So why modify calcium? We know that presence of calcium necessitates greater balloon pressures, and calcium might influence drug-coated balloon efficacy. And if you try to dilate calcified lesion without proper preparation, it may lead to severe dissections. Dr. Fanelli already presented his data that showing that calcium reduces drug-coated balloon efficacy, and the consensus panel suggests that atherectomy should be considered as part of the SFA treatment algorithm for cases of severe calcification. So atherectomy, how it helps us? It helps us to avoid stenting. It helps to prepare the vessel to improve the drug penetration into the vessel wall and modify vessel compliance. There are multiple atherectomy devices are available to us, how to choose and how to pick from them. My choices are for the SFA specifically and popliteal. I use either directional atherectomy or rotational atherectomy, just stream 2.4, 3.4 millimeter catheters. And both of these devices have been shown to provide effective debulking, leading to significant plaque volume reduction and luminal gain. This is one of the studies, definitive AR, directional atherectomy plus DCB versus DCB alone, by Dr. Zeller. What it showed that patients who were treated with directional atherectomy had a high technical success and lower incidence of flow-limiting dissections. When patients especially benefit from the atherectomy, when they had long lesions, more than 10 centimeters, or lesions were severely calcified. Another thing we learned from the directional atherectomy, if you do it, you have to get serious about this and try to achieve the residual stenosis of less than 30%. This is when you get good result. Dr. Garcia already touch upon the reality study. It was the study of directional atherectomy with HOLC1 to debulk moderate and severely calcified femoral popliteal arteries, followed by drug-coated balloon. They looked at primary patency rates at 12 months and as well as freedom from major adverse events through 30 days. They studied really challenging lesions with a lesion length of 179 millimeters, with the CTO also being about 39%. Those lesions were truly calcified. And despite that, they got pretty good result. You see that 12 months primary patency was about 77%, and 12 months freedom from CDTLR was almost 93%. What about Jetstream? What's the data out there? This is by Akiko Mihara, prospective single-arm multi-center study of the treatment effects of Jetstream in moderately to severely calcified peripheral artery disease. They looked at calcium removal and luminal gain as measured by IVUS from pre and post-treatment, looking also at the use of the ejective balloons or stents as the secondary endpoints. What they showed is that luminal area grows with the use of the device, as well as there was a calcium reduction that resulted in 78% increase in lumen area. So this device also provides good debulking and also affects calcium quite a bit. At our institution, we did the direct trial that was prospective open-label single-center one-to-one randomized trial comparing orbital atherectomy with directional atherectomy. There were two groups studied. One was treated with orbital, the other one with directional. All patients had IVUS before atherectomy, IVUS after atherectomy, and then DCB was used, and IVUS again. What it showed that there was a greater reduction in stenosis following directional atherectomy compared to orbital atherectomy, and this difference persisted after DCB. So percent stenosis change post-atherectomy was also greater in the group treated with directional atherectomy. No matter how you slice the data, if you look at calcium severity, lesion length, CTO versus non-CTO, still directional atherectomy provided a better result. There were a few patients who required stents after atherectomy in the directional atherectomy group. The incidence of restenosis and revascularization rates at 3 years, this analysis showed us that there was a significant reduction in restenosis rate in the arm that was treated with directional atherectomy, and as well as a trend in reduction in revascularization rates. It's all in non-stented patients that was treated with directional atherectomy. And freedom of claudication after index procedure at 3 years. Again, there was a trend in improvement in patients treated with directional atherectomy, but if you remove patients who were stented during the index procedure, this difference became significant. Another option that we have now besides atherectomy is a shockwave, which is a great option, especially when distal embolization is a concern and no room for filter, etc. And this is the device that I use, almost exclusively in SFA right now. It's a shockwave E8 catheter that provides, it has 8 emitters and provides uniform emitting of the shockwave throughout the whole balloon. There is another kit on the block. It's called Javelin catheter. It has a shockwave emitter right at the tip, and it helps you to cross subtotal occlusions in very challenging calcified lesions. This is the case that we did. You see there's a lot of calcium distal to the stent that's in the SFA. We treated that. It was very difficult to cross with anything. It was hard to wire. So we treated that with the Javelin, and then followed by the shockwave balloon. And then this is how it looked after angioplasty and after stenting. So there are, we have multiple options. Just get comfortable with whatever you believe works and use it. Thank you.